everyone. My name is Anusuiya Bhorkar, and I am so excited to be here today to present to you Transforming Diagnostics. How can we use artificial intelligence and deep learning for tuberculosis diagnosis? First, a little about me. I'm a rising senior at Dominican Academy in New York City, and I am the published author of The Effects of Data Amount and Variation in Deep Learning-Based Tuberculosis Diagnosis and Chest X-ray Scans. I'm so excited to be presenting my research with you today. So, tuberculosis, an introduction. What is tuberculosis? Tuberculosis is an illness caused by the bacteria Mycobacterium tuberculosis, afflicting the lives of millions today. Rather than a surface transmission, TB spreads through an airborne transmission. Tiny droplets containing M. tuberculosis can get into the air when a person with active TB disease coughs, speaks, or sings. This can be inhaled by others nearby. According to the 2023 World Health Organization, 7.5 million people were newly diagnosed with tuberculosis in 2022, the highest number since the World Health Organization began monitoring tuberculosis globally in 1995. Now, we've established an upwards trend, but we must ask ourselves, who are the people in our global community who need our help the most? Who is being affected? This map shows the estimated tuberculosis mortality rates in HIV-negative people. We can see the mortality per 100,000 members of the population each year, and we can see a correlation between darkly shaded regions indicating higher mortality and the same regions that are lower income communities, lower income countries, and countries that lack the same access to care. The tuberculosis mortality rate without treatment is a whopping 50%. 1 in 2 people who don't receive treatment are dying. The vast majority of tuberculosis-related deaths occur in developing countries, as seen on the map. These countries have a scarcity of medical screening initiatives. Even if the people wanted to get treatment, we don't necessarily have the same diagnostic power in these regions that are necessary for an accurate and timely and effective diagnosis so treatment can even be given. We need to combat this. And we can do so using AI. But first, let's look at some definitions. Artificial intelligence is a concept in computer science referring to machines doing smart tasks, which normally need human intelligence. Neural networks are these tools inside of AI. These are computer systems inspired by the way that the human brain works. Deep learning is a special type of AI usage that uses complex neural networks with many layers to discover patterns on its own. To discover these patterns, AI models turn raw data, such as pixels in a photo, and label it into useful information, such as lesions. This concept can be applied to medical imaging. Deep learning AI models can be trained on medical images using feature extraction. In this training, they learn to recognize pixel patterns from images that reveal lesions, abnormal white patches, or other characteristics of note. Images can then be categorized by relevant categories to aid health professionals. Especially in tuberculosis diagnosis, current diagnostic methods entail cost-wise and time-wise inconveniences with variations in accuracy. The ability of AI to classify medical images shows potential in improving diagnosis accuracy, cost, and speed. Together, we can save lives. So let's take a deeper look, and with that, I present to you my own research. I aim my investigation at the development of a more accurate and efficient diagnostic method, in addition to investigating the impact of different data amounts and variability. I developed 4 deep learning models utilizing the same VGG16 architecture to classify pulmonary X-ray scans into normal and tuberculosis categories. The training was where I differed. Each model was trained on different data sets of pulmonary X-ray scans. These data sets, 4 separate data sets, had varied data amounts and variability, and the 4th one was a combined overall data set. This allowed me to investigate the effects that different data had on the accuracy findings. For the external validation, once trained, each model was then tested on each of the dataset groupings, and the accuracy values were measured. So this is the architecture of the model. On the left-hand side, we can see chest X-rays, normal and tuberculosis, and doctors and medical professionals are able to look at these and indicate signs that show if a patient is more likely to have tuberculosis or not. Now, what my model does is that in the feature extraction layers, the blue convolution and red max pooling layers, it is able to take apart these images and extract the features over time so that we are able to get into the classification layers where we can use the gray flattening and the green dense to ultimately, from all of these features, yield one outcome. and this outcome indicates a positive or a negative read, showing does it have tuberculosis or is it normal? Now, these were my findings. I used an 80-20 split as followed, and the 80% of each dataset was used for training while 20% was used for testing. There were two key takeaways. In all of the models that were trained on a specific dataset, we see that they score in the green category and do fairly well when tested on that same dataset too, even if the specific data was different because it was in the 20 split and not the 80 split. This shows us that models are able to better recognize images that it has seen things in common with, so that it's able to learn and grow to actually apply these skills. However, what we also see is that models that are trained on limited data, for example, the model trained on only dataset A, it tends to do a lot worse on the other datasets as compared to a model such as dataset C, which is a lot better at being applied to the other testing data sets. This shows us that if we do go ahead with this approach in diagnostics, we need to ensure that when we pool together our training data, we want to have a varied amount of data and preferably greater numbers to help that we overcome any bias so that we can actually apply this technology to a wide variety of people who might be suffering from this illness. For our conclusion, our guiding principle is that everyone, regardless of socioeconomic standing and access to care, is deserving of medical treatment. This requires accurate diagnosis. Tuberculosis is most prevalent in low-income countries with lower medical screening initiatives, hence impacting diagnosis timelines. But AI tools are demonstrating novel and efficient ways to aid medical practitioners in forming diagnosis. When we train these AI models, we need to include large amounts of diverse data to help overcome any bias. With the power of technology, let's all work together to create a more medically accessible world for all. These are my references. And with that, I would like to thank my family and friends for encouraging my curiosity and providing me with loving support as I conducted this research. I would also like to specially thank my research mentor, Dr. Ricardo Gonzalez, for his incredible guidance and belief in me. Thank you, Johns Hopkins University and the Global Health Leaders Conference administrators for this special opportunity, providing this platform to be exposed to the amazing world of public health. Thank you so much.